As we said on the general examination, we are looking for any sign or a complication of the cardiac problem on other system. In cardiac examination, the main aim is knowing which chamber is enlarged. This could be get by palpation, and which valve is affected by auscultation. Starting with a quick look, inspection of pericardium for any bulge that seen in patient with congenital heart disease, because cardiomegaly in early life of patient with congenital heart disease, while the chest bone is still not ossified, leading to a bulge that persists on this type of patient, called pericardial bulge. Scar, the classic scar is a median sternotomy scar seen in all type of valve replacement or CABG surgery. And nowadays we have in the modern era a procedure called the minimally invasive procedure for valve replacement, usually for scar below the right nipple, or for CABG called the mid-cap, seen below the left nipple. Dilated veins across the chest might be also seen in patients with superior vena cava obstruction, like bronchogenic carcinoma with SVZ compression. Then moving for cardiac palpation, starting with localization of the apex. Normal apex is in the fifth intercostal space at mid-clavicular line. We should know the orientation, normal orientation of the right ventricle and left ventricle. Normally the right ventricle is anterior and it is a little bit in a horizontal level, while the left ventricle is posterior to it and taking vertical orientation. So if we have the apex shifted outward, this means most probably right ventricular enlargement. And we have the patient with downward shifted apex in the sixth space or seventh space. This denote left ventricular enlargement, and this is the first thing getting by apex localization. Second thing is getting the character, like when we palpating the radial pulse and checking for the character of the pulse. Also, when palpating the apex, we are checking for the character of the apex hitting our hand. If we have what is called the heaving apex, that means that the pulse is hitting our finger and become sustainedly touching our finger. That means this heart is strangulating or straining against an obstruction. This seen in patient with aortic stenosis. If we have a thrusting apex or hyperdynamic apex, this actually occurs in patient with marked volume overload, like in patient with aortic regurg or mitral regurg. If we have something like a tap on our fingers, that is occur synchronous with the systolic pulse, carotid pulse, this actually palpated S1. Palpated S1 occur on tough fibrosis of the mitral leaflet, causing a tapping character while pulsating the apex. This tapping apex occur in patient with mitral stenosis. The second thing is palpating the left parasternal area by the base of the palm of the hand. As we see here and just said that the right ventricle is anterior, left ventricle is posterior. So if our patient have marked RV problem, either enlargement or hypertrophy, this right ventricle might heating our palm of the hand during systole. This is called left parasternal heaving, denoting marked RV, either enlargement or hypertrophy. Then palpating the same area, left parasternal area, by the head of metacarpal bone, because the head of bone is the most points that appreciate a thrill sound. This occur in patient with ventricular septal defect, left parasternal occur in patient with VSD. Then moving upward for palpating pulmonary and aortic pulsation in the second intercostal space. On the left side, pulmonary; on the right side, the aorta, using the tip of finger as seen here. If we appreciate marked pulmonary pulsation, this denoting hypertension and or dilatation in this site. So in pulmonary site, denoting pulmonary hypertension or pulmonary artery dilatation, and same in the aortic area. And again, palpating this area with the head of metacarpal bone for a thrill. A thrill in the pulmonary area usually caused by obstruction, that is pulmonary stenosis, and in the aortic area caused by aortic stenosis. The final site to palpate pulsation is epigastrium. If we palpate a marked pulsation at this area, this actually might be normal in patient with thin body habitus. We are feeling the aortic pulsation, but the abnormality is to get this pulsation on the tip of your finger, that is actually coming from this area, from the right ventricle. And if you feel it at the upper border of your hand coming from this direction, this denoting hepatic source of this pulsation. If you feel it at the palm of your hand coming from just behind, which is usually of aortic origin, as we said, in patient with thin body habitus. Then moving to the most important thing, cardiac examination, which is cardiac auscultation. As we said, the aim of cardiac auscultation is to get a clue about which valve is affected. As we know, we have four valves: two between the atria and ventricle, mitral valve and tricuspid valve, and two between ventricles and great vessels, pulmonary valve and aortic valve. The site of auscultation of this valves actually is a little bit away from the actual anatomical site. This is related to sound transmission and some physics. So where to auscultate each valve? The mitral valve is placed here over the apex, which is at the fifth intercostal rhythmic clavicular line in normal person. Tricuspid valve is here over the left lower sternal edge. The pulmonary valve is here at the second intercostal space at left side, and the aortic valve obstruction is placed here over the first aortic area, which is at the second intercostal space at the right side of sternum, while regurgitation, aortic regurgitation lesion is here over what is called the second aortic area, which just below the pulmonary area at the third space at the left side of the sternum. The remaining space is the fourth space here between the tricuspid and the second aortic area, where we placed here a murmur of ventricular septal defect. So we are auscultating on a Z-shaped manner, starting at the apex, moving to tricuspid area, upward to fourth space for VSD and third space for aortic regurgitation, pulmonary area, and first aortic area. So what we are commenting on during auscultation, first thing is harsh sound. Harsh sound is either first harsh sound, that is called by closure of the atrioventricular valves, tricuspid and mitral valve, and second harsh sound that is caused by closure of the pulmonary and aortic valve. The comment is the sound accentuated or muffled, or there is a splitting between its two components, as we will discuss. The second thing we are commenting during auscultation is abnormal sounds, which is murmur. To get a clue about the origin of this murmur, we should comment where we heard this murmur, the site of murmur, and when we heard this murmur, the time during systole or diastole, and where this murmur radiate, and if there is anything that increase or decrease it. All this give a clue about which valve is affected. Last thing is additional sound. We will discuss it in the coming slides. So back to the first thing, which is harsh sound. As we just said, we have first harsh sound that we comment on it over the origin of this sound, which is mitral and tricuspid closure. So we are commenting on first harsh sound at the apex of the heart, mitral area, and at the left sternal edge over the tricuspid area. This is where we comment on first harsh sound. First harsh sound, as we said, caused by closure of the mitral and tricuspid valve during systole. So what are the abnormalities that could be heard during S1 auscultation? As we said, either accentuation or muffled first harsh sound. Accentuation of the first harsh sound caused by either a problem on the leaflet that become more rigid, causing accentuation of the meeting of these leaflets together, like in patient with rheumatic mitral stenosis, or where the force of closure is rapid or forceful. This occur on high heart rate, on tachycardia. So tachycardia is the most common cause of accentuated first harsh sound. This actually related to some physics of the tension on the chordae of the valve during tachycardia and the volume inside the ventricle during the closure of mitral and tricuspid valves. So to summarize, the causes of accentuation of the first harsh sound is either a disease on the leaflet itself, like in patients with mitral stenosis, or related to the force of closure that increased in tachycardia. On the other hand, the causes of muffled S1 is related to a malcohabitation between the leaflets itself that occur in patients with mitral regurgitation, or decreased force of closures that occur in patients with bradycardia. So mitral stenosis and tachycardia causes accentuated first harsh sound. Mitral regurgitation, bradycardia causes muffled first harsh sound. Then moving towards the second harsh sound. Second harsh sound, as we said, caused by closure of the pulmonary and aortic valve. The mechanism of closure of these valves are by the column of blood inside the pulmonary or the aorta during the end of systole, where the blood pressure is around 120 in the aorta. This column of blood causing meeting of both or the three cusps of aorta and the closure of these valves. So what we are expecting, the causes of accentuated the second harsh sound. If we are talking about the aortic component of the second harsh sound while auscultating the aortic area, this is called by high closing pressure that might be seen in patients with simply systemic hypertension, hypertensive patient. And what are the causes of muffled this sound? This caused by any disease of the leaflet, either regurgitation or stenosis, that limit the meeting of this leaflet. So either any aortic disease, aortic stenosis, aortic regurg caused muffled aortic component of the second harsh sound. And when we are auscultating the second harsh sound over the pulmonary area, then similarly high closing pressure caused by pulmonary hypertension, causing accentuated pulmonary component of the second harsh sound, while any disease in the valve itself, like regurg or stenosis, pulmonary regurg or stenosis, causing muffled second harsh sound. An important thing, where we are commenting in this component, the pulmonary and the aortic. As we know that the closing pressure of the aortic valve is very high, around 120 millimeter mercury, so it is best heard over the aortic area, but it's still heard over the pulmonary area. While the closing pressure of the pulmonary valve is around 25 millimeter mercury, so it is only heard over the pulmonary area, it is not transmitted anywhere. So If we are hearing the second harsh sound over the pulmonary area, then we compare it with the aortic area. If it is the same intensity or higher intensity than that heard over the aortic area, this means accentuated pulmonary component. If it is normally, as we said, it is heard, but the second harsh sound is a little bit less in intensity than that of aortic area, because the difference of closing pressure here around 120 and here is around 25. So normally second harsh sound over the pulmonary area is a little bit less intensity than that of aortic. If it is the same or higher, this means accentuated pulmonary component that occur in patient with pulmonary hypertension. How to time this harsh sound? Simply, S1 occur with while we palpating the carotid pulse simultaneously. S1 with the upstroke of carotid pulse, while S2 on the opposite side when we are not feeling the carotid pulse. This is how to differentiate between S1 and S2, and what are the differential of accentuated or muffled this sounds, and how to comment on the second harsh sound pulmonary and aortic component. Then moving to something called splitting of harsh sound. As we said, each harsh sound is formed of two components, but due to close timing between the mitral and tricuspid closure, it is a little bit difficult to appreciate any splitting on the first harsh sound. On the other hand, similarly, second harsh sound is very difficult to appreciate the difference or the time gap between the two components, aortic or pulmonary. So what is happening that might get this splitting more pronounced? Normally, during inspiration, the systemic venous return to the right side of the heart increased, causing delayed closure of the pulmonary valve, or delayed P2, as we see here. On the other hand, during expiration, there is increase on the pulmonary venous return to the left side, causing delayed aortic valve closure. This is the fact that we should know at first to understand the abnormalities that could be heard. The first abnormality could be heard is wide splitting of S2. That means a wide gap between the aortic valve and the pulmonary valve during inspiration. As we said, during inspiration, there is a little bit delay of P2, but hardly appreciated. When it becomes very clear, while putting the stethoscope over the pulmonary area and asking the patient to take inspiration, we heard a wide gap between the second harsh sound component, aortic, and the pulmonary component. This is called wide splitting. Wide splitting caused by delayed pulmonary valve closure. What are the causes of delayed closure of the pulmonary valve? It is actually related to mechanical problem in the valve itself, like pulmonary stenosis, or mechanical problem in the ventricle itself, poor pumping capacity, like in patient with right ventricular failure, or electrical delay of the right ventricular activation in patient with right bundle branch block. This is the causes of wide splitting. And where to comment on splitting? Actually on pulmonary area, because as we just said on the previous slide, that the pulmonary component of S2 is created by the closing pressure of 25 mm mercury, so it is heard only over the pulmonary area. So if we want a single area where we can hear both the pulmonary valve closure and the transmitted sound of aortic valve closure, this will be the pulmonary area. So we put the stethoscope over the pulmonary area, asking the patient to take inspiration. If we appreciate a wide time gap between the two components, this might denote, as we said, wide splitting caused by pulmonary stenosis, RV failure, or right bundle branch block. Second abnormality is wide fixed splitting. This caused by atrial septal defect. This is pathognomonic for atrial septal defect. How to understand this fixed splitting? During inspiration, there is increase on the venous return on the right side, causing delayed pulmonary valve closure on inspiration. What causes wide splitting during expiration? During expiration, there is increase in the pulmonary venous return on the left atrium, which is actually shunted across the septal defect to the right side, causing also delayed pulmonary closure during expiration. So there is wide splitting that is fixed during inspiration and expiration. This is pathognomonic for atrial septal defect. The last thing is called paradoxical splitting. What is paradoxical splitting? This means that splitting disappear while inspiration and appear on expiration. What causes paradoxical splitting or splitting with expiration? It's actually caused by delayed aortic valve closure. Similarly, it might be caused by mechanical problem on the aortic valve itself, aortic stenosis, mechanical pump failure of the pumping ventricle, which is the left ventricle in patient with left ventricular failure, delayed electrical activation of the left ventricle as in patient with left bundle branch block. So if we asking the patient to take inspiration, then the splitting disappear. This is called paradoxical splitting caused by aortic stenosis, LV failure, or left bundle branch block. Then moving towards abnormal sound or murmurs. As we said before, we should comment on the site where we hear this abnormal sound and time this sound while it's systole or diastole by palpating simultaneously the carotid pulsation while auscultating the patient. As we said before, we move from the mitral area to tricuspid area, left parasternal fourth space, third space for second aortic area, pulmonary area, and finally first aortic area. Starting at the apex, if we hear a murmur over the apex, this means this origin of this murmur. If this highest intensity of this murmur is on this area, this means the origin is on the mitral valve. Then timing with carotid pulsation. If this occur during systole, this caused by regurgitation of blood during systole, called mitral regurgitation. If this murmur here during diastole or during the opening of mitral valve, this means that there is a mechanical obstruction of flow of blood from left atria to left ventricle during opening of the valve or diastole. This is called by mitral stenosis. So we hear a murmur over the apex, then we time this murmur with carotid pulsation. Systolic one is caused by mitral regurgitation, diastolic one caused by mitral stenosis. The same on the tricuspid area. Systolic murmur caused by tricuspid regurgitation and diastolic one caused by obstruction or tricuspid stenosis. How to differentiate between tricuspid regurg and mitral regurg? Simply, any right-sided murmur increase by increased flow across the right side. What normally increase the flow across the right side is taking deep inspiration, which is called Carabello sign. If the murmur increase with inspiration, this is pathognomonic for tricuspid or right side disease, tricuspid regurgitation. Then moving to the pulmonary area, a murmur heard during ejection of blood, during systole, ejection of blood from the right ventricle to the pulmonary circulation is called by obstruction. Obstruction mean pulmonary stenosis. So a systolic murmur would be caused by pulmonary stenosis. Diastolic murmur would be caused by pulmonary regurgitation. Again, how to make sure this murmur is from the pulmonary side? By taking inspiration. If the murmur increases with inspiration, this is pathognomonic for the right side valve lesion. Then to the aortic area, the first aortic area, if we have again a systolic murmur which occurred during ejection of blood from the left ventricle to the aorta, this means mechanical obstruction on the gateway valve, which is aortic valve or aortic stenosis. Then hearing the second aortic area, which is just below the pulmonary area at the third space left intercostal left side of the sternum. This murmur during diastole. This means that there is a regurg of blood during diastole, while the aortic valve normally become closed to avoid return of blood. A disease of valves that cause regurg of blood during diastole is actually aortic regurgitation. And then extra murmurs that could be heard in congenital patient. A murmur of BDA or beta ductus arteriosus, which is a communication between the aorta and the pulmonary artery. Because of the blood pressure inside the aorta during systole and during diastole is always higher than that of the pulmonary, so this murmur is actually continuous during systole and diastole. So a continuous, what's called a machinery murmur on the infraclavicular lesion is pathognomonic for beta ductus arteriosus. Last thing is continuous is harsh pansystolic murmur over the fourth space, which is the best side to hear murmur of ventricular septal defect. So as we said, we are auscultating in a Z-shaped manner: mitral, tricuspid, pulmonary, aorta. Then if we hear a murmur, we comment on where we hear this murmur, and then we time the murmur with the carotid pulse. If the murmur heard with pulsation, this means this is a systolic murmur. A systolic murmur over the mitral or tricuspid valve is a regurgent murmur. On the opposite side, at the pulmonary or aortic valve, a systolic murmur is caused by stenosis. Then, if we hear a murmur with diastole, or as we said, while palpating the carotid pulsation, not hitting our finger in diastole, we hear a murmur, diastolic 1. A diastolic murmur over a mitral or tricuspid valve caused by stenosis. A diastolic murmur over pulmonary or aortic valve caused by regurgitation. Another important thing is commenting on the transmission or propagation of the murmur. The most important thing is the mitral and the aortic valve. Normally, the mitral regurgitation propagated towards the axilla, and the aortic stenosis propagated either to the neck or towards the apex. This is the most common site of murmur propagation. Last thing is commenting in the intensity of the murmur. A murmur, to simplify this issue, if we have a murmur and a thrill felt over the site of the murmur, this is automatically grade 4 plus. If no thrill, this is most probably grade 3. Then moving to extra harsh sound. What is the extra harsh sound that could be heard? An extra harsh sound that heard during the passive feeling of ventricle in early diastole is called S3. S3 denoting increased volume of blood during this passive feeling phase. What causes increased volume? Hyperdynamic circulation like thyrotoxicosis, anemia, volume overload caused by mitral regurgitation, or dilated ventricle with increased volume inside, like in patient with cardiomyopathy. The hitting of the increased flow of blood during the early filling phase of diastole is called S3. On the other hand, exaggerated force of atrial contraction during the late filling of ventricle during diastole is called S4. This is called by a stiff ventricle, leading to decreased compliance of the ventricle and increase the force of atrial contraction that become high enough to be heard, causing S4. This stiff ventricle might be caused by ventricular hypertrophy, like in patients with hypertension or aortic stenosis, or in ischemic myocardium. How to differentiate this extra harsh sound? S3 is early diastolic, so it is close to S2. So if the patient have S3, this could be like this. While on the other hand, S4 is late diastole, close to S1, so should be heard like this. If this extra sound is associated with tachycardia, this is called gallop. S3 with tachycardia called S3 gallop, and seen mostly in patients with decompensated heart failure. If S4 is associated with tachycardia, is called S4 gallop. Then moving to other extra sounds that could be heard. A noise that heard during the opening of mitral valve in early diastole. This is actually caused by marked fibrosis of the leaflet seen in patients with mitral stenosis. The tension on this fibrotic leaflet cause a sound called opening snap. This opening snap is heard like a click just before the mitral stenosis murmur. The other abnormal sound is ejection click. Ejection click is heard over the pulmonary or aortic area in patients with congenital aortic or pulmonary stenosis just before the murmur of stenosis. This caused by pathognomonic dooming of leaflets occur in congenital type of stenosis. The systolic dooming of this leaflet due to tension over it during systole, causing a click sound just before the ejection phase. This is called ejection click. Finally, what is called precardial rub. If we put the stethoscope over the left parasternal area or the base of the heart, and we hear like a friction sound, like two paper friction over itself, this is called precardial rub. How to differentiate between precardial rub and a pleural rub? Actually, the heart is continuously beating, so this rub sound is continuous regardless inspiration or expiration. While if we ask the patient to stop respiration for a while and this sound disappear, this means this is of pleural origin. This is how to differentiate between pleural and precardial rub. Why this rub sound is heard? Because normally there is two layers of precardium, visceral and precardial layer, and there is a little amount of fluid allow smooth movement of the heart during each beat. If these layers become inflamed, become tough, then friction between this both layer cause the rub sound of precardial rub that heard in patient with inflammation on this sac or pericarditis. Moving to the last thing of our lecture, which is prosthetic valve. Prosthetic valve patient who underwent valve replacement, there are two main categories of types of heart valve: tissue valve and mechanical valve. The tissue valve, either surgical one or transcontinuous one, which is a TAVI valve. Usual auscultation is as usual. First and second heart sound are heard as normal. On the other hand, if the patient has valve replacement with a mechanical valve, the closure sound of this valve cause a ticking sound or a clicking sound, like a clock one. This closure sound is heard with systole in mitral position, causing metallic click synchronous with carotid pulsation during timing. It's called S1, metallic S1. And if the patient have aortic valve replacement, this will be a diastolic sound or diastolic click called metallic S2. So this click sound is actually better propagated across bone, so it is best heard over the lower part of the sternum while the patient is sitting. The maximum site of hearing of mechanical valve click, even better heard than the original site of the valve like mitral or aorta. So normally we hear this click with systole in mitral position, with diastole in aortic position. What is abnormal if we don't hear this click? Especially if the patient presenting with acute heart failure and he is not compliant to anticoagulation, then we are thinking of a cardiac emergency, which is stuck valve or thrombosed valve. So the click is not heard. The second pathological thing is any regurgent murmur over the valve. So if we hear a mitral regurgent murmur in a patient with metallic mitral prosthesis, this means that there is a leakage around the valve itself, which is pathological. Similarly, if we hear aortic regurgitation murmur in patient with aortic valve prosthesis, this is also pathological, denoting a leakage of blood around the prosthesis. On the other hand, a stenotic murmur might be heard over a metallic prosthesis due to increased turbulence of flow during opening of this valve, but this is might be accepted to a limit. If this stenotic murmur like ejection murmur over aortic mechanical prosthesis is associated with thrill or transmitted to the neck, this means this is pathological. This is not a flow murmur. This is a pathological one and should be better evaluated with further investigation like echocardiography. So to summarize our lecture, as we said before, general examination of cardiac patient aiming to pick a cause or a result of cardiac problem, starting from a general look, then circulating starting from the hand, head and neck, leg, abdomen and lung, then local cardiac examination with palpation to appreciate which chamber is enlarged, and auscultation to get which valve is affected. And this a good website where there is many records of different heart murmurs. This for better practice. And finally, thank you.